In this section, I'm going to discuss the pathophysiology of cerebrovascular accidents, otherwise known as strokes. Now, there are two major types of cerebrovascular accidents. There are ischemic CVAs, and these are due to loss of perfusion. And there's two main types of these, although we really can think of three. There are ischemic strokes that are due to thrombus, and a thrombus is usually a narrowing of a relatively large vessel. So it might be a thrombus here or a thrombus here, and this is like an atheroma. So it's from atherosclerotic disease that narrows a vessel that supplies the brain. And it's usually a large or mid-sized vessel. Okay. And the next type, I'll use a different color blue here, would be an embolic stroke. And an embolic stroke is a clot or some kind of debris that breaks off from somewhere else in the body and travels up through the arteries into a small artery where it lodges. And when it lodges, it cuts off all the blood supply to a specific area of the brain. Now, thrombotic causes strokes about 50 to 60% of the time. Embolic causes strokes 30 to 40% of the time. So ischemic strokes are by far the most common. Now, I hinted at a third type of ischemic stroke, and they are much more rare, but they are just caused by global hypoperfusion. So we see this in patients that maybe go to the operating room and their blood pressure is too low for too long, and that can cause a stroke. And that kind of stroke tends to be very diffuse, and the damage tends to be in areas throughout the brain. And also it can occur after a cardiac arrest, and this is otherwise known as anoxic brain injury, and we're going to talk about that separately as a separate entity. Okay, now the second type of stroke. They're more rare, but we always need to consider them because they're very dangerous. And interestingly enough, the treatments that we have for ischemic strokes are to use very powerful anticoagulants known as thrombolytics. And they can work well for ischemic strokes, but they would be disastrous for obvious reasons to give to a patient with a hemorrhagic stroke. So it's very important, if you have a patient that has had a stroke, that you need to differentiate whether they have an ischemic stroke or a hemorrhagic stroke. So hemorrhagic strokes occur about 10 to 15% of the time. And again, there are two types of hemorrhagic strokes. There is a subarachnoid bleed, which is usually due to an aneurysm of a large or mid-sized vessel, as we see depicted here. So an aneurysm of a vessel where a wall is weakened, often due to atherosclerosis. So you have a sclerotic that weaken, and we're going to talk about aneurysms when we get to the cardiovascular section a little bit more. So an aneurysm usually is in a larger vessel. The circle of Willis and all of the vessels that break off from the circle of all of its main branches are up above where the meninges start. So if there's a bleed in any of the vessels in the circle of Willis or branching off of the circle of Willis that have an aneurysm that burst open, you're going to have a subarachnoid bleed. Now, the other type of hemorrhagic stroke is an intraparenchymal bleed or an intracerebral bleed, whichever terminology you prefer. Parenchyma is just a word for any organ tissue. So brain parenchyma, you can have liver parenchyma or whatever. So an intraparenchymal bleed would be otherwise known as an intracerebral bleed. And these are bleeds that occur in smaller vessels. So they occur in tiny vessels here, and I probably could draw this a little bit better with red. So you may have a little tiny vessel up here. And the most common cause is from little AVMs. Now usually you have an artery that drifts down into a really tiny capillary, and then the capillary drains into a vein. But there are some people, probably because of genetic inherited genetic mutations, they have a tendency to develop these arterial venous malformations, which are these little pouches where arteries and veins come together in this tangled little mass. And these have a propensity to bleed because you have places where you have the thick-walled arteries pumping blood under high pressures into thin-walled veins, and they can burst open and bleed intraparenchymally. Here, it'd be easier to see the blood if it's red. So that would be an intraparenchymal bleed. Okay, so those are the major types of stroke. Okay, now it's interesting. All of the types of stroke involve something to do with the vasculature, right? So I'm going to talk about vascular disease. So diseases of the arteries can cause thrombi, they can cause emboli, and they can cause aneurysms. So I'm going to briefly talk about atherosclerosis. And again, atherosclerosis is going to be discussed more in depth in the cardiac section. Let's give a little introduction to atherosclerosis. So this is a picture of an artery. And arteries have three layers. They have the intima, which is covered with endothelial cells. And the muscular layer, and those are the layers we're going to be talking about today, primarily. Now, what happens with an atheroma is, and again, I'm not going to get into all the biochemical aspects of it at this point, but atheroma it's an inflammatory process that causes a infiltration of lipids, specifically cholesterol, and a lot of inflammatory cells and mediators that develop the sort of inflamed brew in between the intima and or the endothelial cells and the muscularis. Now, they can start off, just slightly thickening the wall of the artery, and as they develop, they thicken it more and more. Now, as they thicken it, the lumen of the artery gets thinner and thinner, and this plaque here is known as a thrombus. And the larger a thrombus gets, the narrower the lumen gets. And the narrower the lumen is, the less blood that can flow through it. Okay? And if this gets narrow enough and decreases blood flow enough, then you're going to rob the brain of enough of a blood supply, and when it crosses a critical threshold, you're going to have symptoms of a stroke. Now, sometimes people will have a TIA first when they have a thrombus, because they may start having early symptoms that are transient because the lesion is sort of on a borderline status. If your brain is requiring a lot of blood flow at a given time, the arteries may not be of sufficient size to deliver the blood flow that's necessary, so you will start to have symptoms. And then when blood flow decreases, the symptoms are going to dissipate. Okay. All right. Now, an embolism can come from actually several different areas, but one area that it can come from is if the plaque continues to develop and it becomes complicated, it has a surface defect that sort of the surface of the atheroma breaks open. You're going to have a lot of inflammation, and you're going to have a hematoma that develops around that broken area, and the thrombus can break off and cause an embolism. Okay. So an embolism, and usually this will break off in any vessel that's between the heart and the brain. So this could happen, the carotids. Oftentimes, if a patient has an embolic stroke, after getting treated for the stroke, they will then get a carotid endarterectomy because they are having because they're flecking off plaques from the carotid artery. And also, actually, having significant thrombi in the carotid artery can cause ischemic strokes just because of the loss of the lumen size of the carotid artery. Emboli could really come from any vessel from between the heart and the brain. So carotids, vertebral arteries, and other places emboli can come from are from the heart itself. So the heart has 4 chambers. It's got the 2 atria and 2 ventricles, right? Now, the left ventricle pumps up into the aorta. Now, if you have atrial fibrillation, the atria are just quivering. And because they're quivering, they're not pumping blood out into the left ventricle very efficiently. So the blood just kind of pools off in the corner here, and a large thrombus can form, and parts of it can fleck off. And let me draw this in a different color. Parts of this might fleck off, travel through the left ventricle up into the aortic arch, go up through a carotid and into the brain. So that's another source. Another source may be the aortic valve. Sometimes you can get vegetations on the aortic valve from bacterial infection, and one of the common critters that is chlamydia. So you can have a chlamydia infection that causes growth of bacteria and large depositions of debris that form on the aortic arches, and these can fleck off and cause emboli. You can also have emboli that form if you have a patient with very bad CHF and a huge dilated left ventricle and an EF of like 10%, you're not going to get good blood flow through the left ventricle, so you may end up with a left ventricular thrombus or an LV thrombus, and the same process can occur as part of it can fleck off and lodge in the brain. That's a very dangerous condition. So there's lots of different ways that you can embolize. Another way that you can embolize actually is if you have a patient with a DVT. So down on the leg, you might have a DVT and a big clot forms. What happens when this breaks off? Well, usually, it goes up to the right side of the heart, and typically it'll go through the right ventricle and into the lungs, and you'll end up with a pulmonary embolus. But there is a sizable population of people who have a patent foramen ovale, so there is a direct link between the atria, the right and the left atria. So the embolus from the DVT can actually cross from the right side of the heart to the left side of the heart and work its way up into the brain. And I had a patient like this in the ICU not long ago that had a DVT and developed a stroke, and lo and behold, we did an echocardiogram and found out that they had a patent foramen ovale, and that was their source of stroke. Okay, so we've talked about 2 different major types of strokes, ischemic strokes, which can either be thrombotic or embolic, and hemorrhagic strokes that can be either subarachnoid bleeds or intraparenchymal bleeds. Now let's talk a little bit about what happens after the stroke occurs. So here I have a picture of a CT scan of 2 different patients that have had 2 different types of strokes. Now this area here is an area of this is a collection of blood. So this is a hemorrhagic stroke. Now, interestingly enough, this stroke is not in the subarachnoid space, which would appear, sort of off to the side, and possibly in the ventricles as well. This is an intraparenchymal bleed. Okay. Now, over here, we have someone with a CVA, and this is an ischemic CVA. Now, interestingly enough, you really don't know. With a hemorrhagic stroke, you can do a CT scan and tell right away. Within minutes, you can say, okay, this is a stroke and it's a hemorrhagic stroke. With an ischemic CVA, you're not going to see any changes at all. It's going to take hours and possibly days before you see any changes in the CT scan at all. So this is a CT scan of a CVA that is days old. And even when it's days old, I don't know, just looking at the CT scan, whether this is an embolic stroke or a thrombotic stroke. I'm going to have to do further workup to find the source of what cut off the blood supply to the brain. So is this thrombotic? Is this embolic? We don't know yet. We're going to have to do a workup. We're going to do an echocardiogram to look at the heart. Is the patient in atrial fibrillation? Do they have a clot in the atrium? Does the patient have a low EF? Do they have a clot in the left ventricle? Let's look at the valves. Do we have any vegetations on the valves? Then we're also going to look at the carotids. Do we have a huge thrombus in the carotids? We'll do a carotid ultrasound. Oh yeah, does the patient have a PFO as well on the echo? Then we're going to look for other potential sources. If we don't see any sources for an embolic stroke, we're going to start to look at sources for a thrombotic stroke, and we may need to do a cerebral angiogram where we look at the blood flow through the vessels to the head. So we don't know whether it's embolic or thrombotic until we do a much more extensive workup. Okay. But anyways, whether this is thrombotic or embolic, we do know that it's ischemic, although it's many days old. And this is a huge stroke. This is a stroke that is affecting most of the left hemisphere of the brain. And so this patient is in a bad way. Although, usually when you look at a scan like this, the chances are that the patient is not going to regain meaningful function, but I can never say never, because I have seen patients with strokes of this magnitude that have still gone on to wake up, and they regain language function and are able to move. So you really cannot predict just based on the amount of damage that's done to the brain. Now, both of these CT scans have something in common. A typical CT, and I probably should have put up a normal CT scan. A typical CT scan will have a nice symmetrical brain, and you can see the brain whoops, I'm not drawing a very symmetrical line. We usually have clear symmetry on both sides, and you'll see the lateral ventricles, and they'll both look exactly the same in just the right shape. And with these brains, you see a shift. So you can see where the brain should be here. Instead of being straight symmetry, you see a shift from the left side to the right side. And this shift is due to something called the mass effect. And in the case of the hemorrhagic CVA, the intraparenchymal bleed, the mass effect is due to the space that is occupied by the blood. In the case of the ischemic stroke, the mass effect is caused by brain swelling. And both of these are causing an occupation. Now you can also have other conditions can cause mass effect. You can have mass effect from a subdural bleed. You can have mass effect from a cancerous mass. And lots of other things. But the problem with mass effect is that it will cause a secondary injury because the skull is not flexible, and most of us with healthy brains don't have very much space in between the brain and the skull. So without a very large mass without very much bleeding or swelling, we're going to use up all the extra space in our brain. We're going to collapse all of our ventricles. You can see there's no ventricles here on the left side. Um, and we're going to begin to have a shift from the left side to the right side. So we have no ventricles here, and once we've collapsed our ventricles and begun to shift, then we no longer our skull no longer has any capacity for more volume. So what's going to happen is the brain tissue that's remaining is going to be compressed, and when it gets compressed up to a pressure above normal intracranial pressure, when you get up, I think to, it's been a while since I've worked in neuro, but I think up to 10 or 12 millimeters of mercury, then you're going to collapse. You're going to be above venous pressure and above capillary pressure. So you are no longer going to perfuse the brain tissue well. Okay, when that happens, you're going to enter a vicious cycle. Here, let me move down a little bit here, because what's going to happen is you're going to damage more neurons. And when the neurons are damaged, they release inflammatory mediators and cause more inflammation, and that's going to cause more swelling, and that's going to increase your mass effect, and you're going to increase the pressure even more, and the cycle is going to continue until you get to a point where you herniate your brainstem through your skull, and that's going to lead to death inevitably. Okay, so mass effect can occur for a number of reasons. Either stroke can cause mass effect if they're large enough, and various injuries can cause mass effect as well. Okay, so that's the basic overview of the pathophysiology of cerebrovascular accidents.